First of all, I would like to thank the scientific committee for choosing me today to present with you. Our talk today is about the role of antimicrobial prophylaxis in pediatric acute leukemia. And this is the outline of the presentation today. We're going to talk briefly about the antifungal prophylaxis, followed by the antibacterial prophylaxis, and in both topics, we'll go through the summary of recent updates and recommendations. For the antifungal prophylaxis, first of all, we're going to start with talking about the incidence, then the significance, then the chemoprophylaxis, and the recent guidelines. And as we all know, that fortunately, recently we had a good improvement in the management of infectious complications over the last 60 or 70 years. And if we go through the incidence of the invasive fungal disease in children and adolescents, we're going to find that using intensive chemotherapy has made these patients at high risk for invasive fungal infections, with its impact on morbidity and mortality of these patients. In this German study, which was a large autopsy study in Germany, as you see, the prevalence of invasive fungal disease is steadily increasing over time, starting from 1977 to 2005. And with the prevalence of the Aspergillus having more than 60% than Candida. When talking about the journey of an acute myeloid leukemia patient of this population, you can find the cumulative incidence of invasive fungal disease to be 8 to 12%, mainly during the induction chemotherapy, accounting for more than 60%, and only 3% during the journey of consolidation. Looking for the acute lymphoblastic leukemia patient, you're going to find that the cumulative incidence is lower. However, the acute lymphoblastic leukemia patients is really a heterogeneous group, especially nowadays having low risk and very low risk, standard risk and high risk groups. In a recent German study, the high risk groups had achieved about 10% cumulative incidence of invasive fungal disease, especially in patients that did not enter remission by day 15, and also to those who are older than 15 years old. Actually, yes, these are data that has not been published on publication right now in the Lancet. Looking to in this paper by Lilian Sung, where she had, which was the larger study in the pre-prophylaxis era, where she looked for the microbiologically documented infections and infection-related mortalities in children with acute myeloid leukemia. Actually, and surprisingly, she found that apart from the Streptococcus viridans, the fungi were also very prominent, and with an infection-related mortality of the aspergillosis accounting for more than 31%, and the Candida for 26% of infection-related mortality. Talking about the clinical significance of invasive fungal disease in this study by Zayutas that has been published in Pediatrics in 2006, where he studied about more than 600 pediatric cases of invasive aspergillosis were found among immunocompromised patients in the United States. And when he looked about the impact for the median length of hospital stay and the charges for these patients, it was just like those with invasive aspergillosis has more than 16 days of hospital stay versus 3 days for those without, and for the cost it has risen tremendously, or about $50,000 versus $10,000 in those with non-invasive aspergillosis. And in the same study, when he looked into the mortality, invasive aspergillosis significantly increases in hospital mortality in the immunocompromised children. And now, for when we do have the question of why do we have to prevent this invasive fungal disease, direct and indirect mortality of invasive fungal disease is unacceptably high, with no validated tools to reliably detect invasive fungal disease at an early time point. There are different strategies, whether non-pharmacologic, immunomodulation, or chemoprophylaxis that we're going to talk briefly within the upcoming slides. For the non-pharmacological prophylaxis, you can have just by decreasing the exposure, wearing masks, using HEPA filtered rooms, And for the immunomodulation, you can use the GCSF to shorten the periods of neutropenia. However, before going to these chemoprophylaxis, we have to know the risk factors that makes our patients at a higher risk, especially the neutropenia, whether it's profound or prolonged. Use of glucocorticoids, the mucosal tissue damage caused by the immunosuppressants were given, and also limited to the invasive candidiasis, the presence of central venous catheters. Now comes the question of who is at high risk, or whom to give to prevent invasive fungal disease in. While the term high risk is not properly defined, a natural incidence rate of invasive fungal disease of 10% has been accepted widely to give these patients antifungal prophylaxis. But we have to state strongly that the local epidemiology is an important additional consideration for designing an appropriate institutional prophylaxis strategy. And it is, as mentioned in the ISIL guidelines for the certification of risks of invasive fungal disease, that those with high risk of 10% are the acute myeloid leukemia patients, recurrent acute leukemias, allogeneic hematopoietic stem cell transplant, and high-risk acute lymphoblastic leukemia. Nevertheless, that the low risk and sporadic occurrence does not mean that there is no incidence of invasive fungal disease, and individual risks should be weighed thoroughly. Now for the question, what to give to these patients, or which compound should be given to them. According to the ECL guidelines and the meta-analysis that had been done, we have the fluconazole and the posaconazole with the strength of recommendation A. And actually, for the posaconazole, it's so much debatable. For instance, the patient, it is indicated and FDA approved in the US to be given to all patients to less than 18 years of age. However, in the European Union, it had not just been approved, except for those who are older than 13 years. And for the mold-active triazoles, drug-to-drug interaction needs to be carefully considered. And for the use of vincristine with these drugs, it's contraindicated to use it with vincristine due to potential aggravation of polyneuropathies. And for all the azoles, the therapeutic drug monitoring is suggested. Then the target concentration should be measured. And also, it's worth noting that the spectrum includes both yeast and molds approved indication for adults for the posaconazole. As for the itraconazole and the voriconazole, they are actively against most yeast and molds as well. And for the voriconazole, it's very important that therapeutic drug monitoring, keeping the trough concentration levels from 1 to 5 is mandatory. The one with also that has the same recommendation B is the liposomal amphotericin B. Although it has a spectrum against yeast and molds, it has not been approved for prophylaxis, not for the adverse events, but because no randomized controlled studies for liposomal amphotericin B has been conducted, and we don't know a fixed dose nor regimen to be used as a prophylaxis. However, it is considered an alternative option for patients who do not tolerate triazoles or have concentration regimen. As for the echinocandins, the micafungin, it is now accepted as prophylaxis with the coverage of Candida and Aspergillus in acute myeloid leukemia patients. And for the caspofungin, when these guidelines were discussed, there was no yet results, randomized controlled studies for the caspofungin, so it was not graded. However, let me show you this study by Lillian Sung, by Brian Fisher and Sung, Dr. Sung, about the effect of caspofungin versus fluconazole prophylaxis on invasive fungal disease among acute myeloid leukemia, where the caspofungin was studied in regard of efficacy versus the fluconazole, with an outcome, an accumulative incidence of 3.1 in the arm of caspofungin versus 7.2 in the arm of fluconazole. And that's why it has been proven to be very highly efficient. Talking about meta-analysis and randomized control studies for the use of antifungal prophylaxis as well in the pediatric patients, apart from the ISIL guidelines, we can find this meta-analysis that has revived more than 160 randomized control studies and meta-analysis. in studying the mold-active agents, amphotericin B, echinocandins, and other triazoles apart from the fluconazole versus the fluconazole. And as we can see, that it has been proven that they are highly efficient for the amphotericin B, for the echinocandin, and for the other triazoles against the fluconazole. And also, it's worth noting that they have strongly recommended this panel is that in choosing a mold-active agent, you can administer an echinocandin or a mold-active azole, keeping in consideration the type of patient, the age, the drug interaction, the costs, and local epidemiology, of course. And for the liposomal amphotericin B, it was not included in these studies because there was no randomized controlled studies for liposomal amphotericin B versus the fluconazole. Just before leaving this, we do have a study at 57357 studying the efficacy of microfungin prophylaxis. And as we said that antifungal prophylaxis has a good deed, it may have a bad deed as well. So in our patients, we were surprised to have a 10% breakthrough invasive fungal infection. We did have 50% of candida resistant to echinocandins and 50% of other aspergillosis cases. So in using antifungal prophylaxis, you should always keep in consideration the breakthrough invasive mold infection that can occur. And in this review by Contanianus and Linacus, he had stated that there is a timing for the breakthrough invasive mold infection that should be kept in consideration, whether early or late, and accordingly you can react. And knowing the class that you have been using or administering at the break on antifungal prophylaxis can dictate the workup that you can do. In conclusion, invasive fungal disease has a significant morbidity and mortality, and antifungal prophylaxis is reasonable. All antifungal prophylaxis is recommended for those at 10% risk of developing invasive fungal disease. And for the practice guideline, based on the randomized control studies, echinocandins or triazoles can be used, are okay to be used, but there is an unclear role for liposomal amphotericin B. And breakthrough fungal infection should be kept in consideration with the local epidemiology and the class of the antifungal you're using. And turning now to antibacterial prophylaxis, we're going to go thoroughly through some of the randomized controlled studies and meta-analysis. Then the paper by the JAMA publication, which was the Koch trial, about the use of levofloxacin prophylaxis, and then the ECL recommendations and the updates. As we said, the invasive fungal disease has a considerable morbidity and mortality. The same is for invasive bacterial infection as well. Moreover, the prophylaxis and treatment is highly variable between countries, not only countries, maybe between institutions as well within the same country. And when we see this guidelines that has been published in the CID after revision of randomized controlled studies and meta-analysis, more than 60 studies has been gone through to search the history of antibacterial prophylaxis. And the question addressed was whom to give, which agent, and when. And actually speaking, starting from my history, that the studies that has the fluoroquinolone versus no antibiotics, there was so much studies that has bound to be effective in terms of bacteremia, fever, and neutropenic fever, where the prophylactic arm has tremendously decreased the occurrence of these, with no significant effect on infection-related mortality or overall mortality. However, there has been a signal of development of antibiotic resistance on the long term of use of fluoroquinolone prophylaxis. And in other studies, studying fluoroquinolone versus trimethoprim sulfamethoxazole, there was no significant difference between both agents in terms of bacteremia, fever, infection-related mortality, and infectious diseases, invasive fungal diseases. Being a pediatrician, when looking to the pediatrics randomized controlled studies in this paper, they have studied that they found 13 randomized controlled study. The most recent of them was fluoroquinolone versus no antibiotic, which was detected in 3 studies dating from 2013 and 2018. And let me take you to the journey of this JAMA publication, the most recent study which studies the efficacy of levofloxacin prophylaxis on bacteremia in children with acute lymphoblastic leukemia. And this actually was one of the largest randomized controlled study done by the COG. And the objectives of it was to see the efficacy of the levofloxacin in decreasing bacterial infection and versus the adverse events, the potential adverse events that can come. And in these patients, they have in this study, they divided the patients into two strata: the high risk acute leukemia, compromising the acute myeloid leukemia, the relapsing acute leukemia, and the high risk acute lymphoblastic leukemia, versus the other stratum, which was the hematopoietic stem cell transplant. And here they administered the levofloxacin was administered for the 2 consecutive cycles, starting from the start of neutropenia until the recovery. Moreover, they have looked deeply into the resistance. They have monitored the resistance in colonizing GI organisms and the adverse events in terms of musculoskeletal adverse events that the levofloxacin has been accused of at 2 and 12 months post completion of the study. And actually, there have been more than 600 patients enrolled, and for the acute lymphoblastic leukemia arm, it was just 200, because during the interim analysis, the DSMC has halted the accrual as the efficacy crossed the efficacy boundary. And in terms of results, actually, for the levofloxacin arm, as you can see that the incidence of bacteremia was 21% versus 33%, with a risk reduction ratio of 0.5, and this was highly significant. And for the isolated microorganism, the levofloxacin arm, there was a much decreased in bacteremias in subsequent cycles, having 19 versus 27 in the non-prophylactic arm for the gram-positive and 5 versus 20 in the gram-negative arm. As for the secondary outcome, the levofloxacin arm significantly decreases the fever and neutropenia as well as the C. difficile. Also, they have looked thoroughly through the antimicrobial exposure, and fortunately, the levofloxacin arm, there was a decrease in the broad-spectrum antibiotic used, whether aminoglycosides, third-generation cephalosporins, or the empiric therapy for fever and neutropenia. As for the resistance, which is now been addressed thoroughly by other studies as well, the proportion of isolates resistant to levofloxacin among those tested for levofloxacin sensitivity, it was almost 8 out of 8. And actually, this was not shocking. So since you're giving you're growing a bug on levofloxacin, so you actually most probably going to be resistant. As for the control group, it was just only 2 out of 17 resistant to the levofloxacin. In conclusion, they have the conclusion of that the levofloxacin reduced bacteremia, no increased in adverse events, and we have less antibiotics exposure. Going thoroughly through the ECL guidelines and the way they started, they tried to have the recommendation, they addressed the same questions nearly in this term of application, whether the mortality, bloodstream infection, febrile neutropenia, resistant emergence, collateral damage, infections, and adverse effects. And actually, the results were the same as in the publication I've showed earlier, in that in terms of mortality, there is no reduction. In terms of bloodstream infection and fever neutropenia, there was a reduction. However, the adverse effect and the collateral damage, there was nothing significant. And for the fluoroquinolone resistance, some studies have shown that there is increase in the proportion of frequent fluoroquinolone resistance among bloodstream isolates. So, with the recommendation of the level of D3, the routine antibacterial prophylaxis is not recommended for pediatric patients with lymphoma, acute leukemia, relapsed ALL, or undergone hematopoietic stem cell transplant. Actually, for the same paper I've shown earlier, in the meta-analysis and the mice control studies, we have the recommendations by this panel, which was very interesting, since they have considered administering antibacterial prophylaxis for patients with acute myeloid leukemia and relapsed ALL with expected severe neutropenia for at least 7 days, and they have given it the conditional recommendation. And why conditional, or what's the meaning of conditional? They have given it, they were weighing the cost-benefit effect of these recommendations in terms of For the German publication, levofloxacin was used for just 2 consecutive cycles with a small signals of rising antibiotic resistance. However, they've given the institutions and the practitioners a way to see, according to their local epidemiology and practice and experience, whether or not to use the levofloxacin or whatever prophylaxis it's going to be used, antibacterial. And also, they suggested the use of antibacterial prophylaxis not to be used routinely for ALL patients receiving induction chemotherapy. And they stated also it's a conditional recommendation, so you can take it or leave it. However, for this recommendation specifically, in the AL patients, it was because of the large number of the large volume of acute lymphoblastic leukemia patients, which can cause a negative impact or change the microbiological epidemiology of the patients at the institution. Also, the incidence of bacterial infections occurring in induction chemotherapy is so far less than that occurring during acute myeloid leukemia induction. Also, they recommend not to use systemic antibacterial prophylaxis for those who are with not severe neutropenia. And they have given this a strong recommendation. As for the autologous hematopoietic stem cell and the allogeneic hematopoietic stem cell transplant, they have given it the conditional recommendation as well. And finally, for stating which antibiotic to be given, it's the levofloxacin that is the preferred if systemic antibacterial prophylaxis is planned. And this has been approved with a strong recommendation, especially after the COG trial. And also, when to give, it has just been restricted to the expected period of severe neutropenia until recovery from neutropenia. So, at the conclusion, after talking about the antibacterial prophylaxis, you can see that we still have gaps for the antibacterial prophylaxis to be approved. First of all, as you can see, the risk and benefits of prophylaxis is different in different settings. We cannot reach a consensus in it. For example, for the acute lymphoblastic leukemia patients, we have low risk, very low risk, standard risk, high risk, and each of them have its own risk for infection. To prophylax has proven to be good versus not to prophylax, which is not perfect. Still, we have 20% of incidence of bacteremia in acute myeloid leukemia patients. So actually, we need more intervention. As in terms of efficacy, we can say that for now we have the use of levofloxacin for the 2 consecutive cycles has proven efficient with 20% bacteremia. However, is this going to be the same with the prolonged use of antibiotics, antibiotic prophylaxis? Is there going to be more resistance on the rise? Nobody knows. However, further randomized controlled studies are needed to show this. And by this, I'm ending my talk. And thank you for being attentive. I'm ready for questions. Thank you.